Hi, my name is Dang Lee, and today I'll be talking about doing manual techniques for DeQuervain's syndrome. So the four techniques that I would choose to do are friction massage, joint mobilizations and mobilization with movements, and last but not least, neural sliders. I'll briefly mention indications and contraindications, and the rest will be listed below in the description of my video. So first, with friction massage, see your hand? After an injury, usually your body will put down connective tissue that is in a randomized order like this. It's kind of like a ball of yarn, and this is just to provide temporary strength to it, whereas normal tissue is like this, gauze, and is straight and have this weave pattern to it, and is stronger and provides flexibility to the tissue. So what you're going to do is go to the inflamed area, and since the tendon runs straight, I'll be providing a perpendicular force to it at about moderate pressure. And then the patient may feel some discomfort with this technique. That is normal, but it shouldn't be too much pain as where they can't handle. And then about 1 or 2 minutes, what you would do is ask the patient how they feel, and then if they report less pain, you provide more pressure and continue. And usually we want to go for about 10 minutes. And then with this technique, the main indication is for any inflammation of a tendon, and then contraindication is for any skin disease or inflammation due to bacterial or viral infection. And then afterwards, you always want to ice with this technique. So next, we're talking about joint mobilizations. With DeQuervain's, patients tend to have pain at the base of their thumb, so they end up not moving their wrists as well. So when we test their range of motion, we will see where they're limited, and then improve their range of motion with joint mobilizations. And that's basically restoring the joint to a normal position within the hand so that it can move better again. Indications are loss of range of motion, and contraindications is hypermobility and inflammation due to any systemic issues. So the hand is a convex while the radial owner are concave. So applying that rule, what we would do is first provide a grade 1 distraction, and then we apply a volar glide. This would promote extension, and then dorsal glide would be promoting flexion. Alright, and then next is mobilization with movement, and that's the contraindications indications basically the same thing, but then with addition of pill. So think of PILL. P is for pain-free, I is for instant result, LL is for long-lasting. And this is basically combining movement with the joint mobilization into a position that the patient prefers with no pain. So first, I would find a patient's comparable sign, what the patient likes best. So getting my patient's hand, I would apply, let's say, a supination along with a flexion and extension, or pronation with flexion and extension, or even an ulnar and radial glide with a flexion and extension, and see what reduces the patient's pain. So let's say my patient liked flexion and extension with ulnar glide. So let's have you stand up, sir, and put your hand down on the table like this. So I'll be stabilizing his arm with my left hand, providing ulnar glide with my right, while he rocks his body forward, providing that movement into wrist flexion and extension. Okay, so that's mobilization with movement. And last and not least is neural sliders. This technique is for the patients having sharp, burning, radiating pain, and our other treatments for the DeQuervain's didn't work. So now we would treat the patient for superficial sensory nerve. Also, this nerve can sometimes get injured in the case of DeQuervain's as well, as the inflammation gets bigger and starts to entrap that nerve. So, indications for this technique is basically what I mentioned, and positive testing on upper limb tension testing. And contraindications for this technique are we're suspecting signs of metastases or the neurological signs are worsening. So I'll have my patient lay supine down on the table over here. Okay, and now I'll get his arm out into abduction, about 30 degrees or so. With my right hand, I'll be depressing his shoulder, bring his arm up into elbow flexion, my right leg supporting below the elbow. I'll move his wrist into flexion, some ulnar deviation. Slowly bring him down to extension, as this technique is pretty intense. They might feel some pain with this, especially in acute stages. And now that he's down to full extension, I'll have him bring his right ear down to his right shoulder, as his wrist is still flexed. Okay, and now bring his left ear to his left shoulder, and I should decrease that wrist flexion. And this is, and again, same thing. And this is just putting tension on and off that radial nerve to try to move it out of the area of entrapment. And these are the 4 techniques that I would do for DeQuervain's syndrome.